Section 1. Cracking the NCLEX code. Why chest injuries matter. Chest injuries represent a significant portion of questions on the NCLEX because they directly threaten the fundamental principles of life. Airway breathing circulation. A patient with a compromised chest is a patient in immediate peril, and the exam will rigorously test your ability to recognize these life-threatening situations and act decisively. These questions are not designed to trick you. They are designed to ensure you are a safe and competent entry-level nurse. Knowing how to assess a patient with chest trauma, identify the specific injury, and implement priority nursing interventions. It is not just about passing a test. It is about having the foundational knowledge to save a life in a real-world clinical setting where seconds can make all the difference. This guide is meticulously crafted to serve as your roadmap for acing these critical questions. We will strip away the fluff and focus exclusively on what you absolutely must know for exam day. Our primary goal is to empower you with the clarity and confidence needed to tackle any scenario involving chest injuries. Simple rib fractures, complex tension pneumothoraces. The learning objectives are straightforward and exam-focused. By the end of this essay, you will be able to articulate the essential anatomy, pneumothorax, hemothorax, and detail the intricate steps of chest tube management. This is your comprehensive study tool for mastering chest care. Your success on the NCLEX hinges on your ability to apply theoretical knowledge to practical, high-stakes scenarios. Select all that apply priority action formats which demand a deep understanding rather than simple memorization. For instance, you will need to know not just the signs of a pneumothorax, but also which sign indicates it has escalated into a life-threatening tension pneumothorax. You will need to know not just that a chest tube drains fluid. Section 2. The blueprint of breathing. Essential anatomy and physiology. Here's how a healthy chest keeps you breathing. To understand what goes wrong in a chest injury, you must first have a solid grasp of how a healthy chest works. The chest cavity, or thorax, is a protective fortress for your most vital organs, the heart and lungs. This fortress is built from the rib cage, which shields the delicate lung tissue from external force. The primary muscle of respiration is the diaphragm, a large dome-shaped muscle located at the base of the chest. When you inhale, your diaphragm contracts and moves downward, while the muscles between your ribs, the intercostal muscles, pull the rib cage up and out. This coordinated movement increases the volume of the chest cavity, creating negative pressure that pulls air into the lungs. Breathing is a beautifully simple, yet exquisitely complex process. The lungs themselves are housed within the rib cage, but they are not directly attached to it. Instead, each lung is wrapped in a thin, two-layered membrane called the pleura. The visceral pleura clings to the surface of the lung, while the parietal pleura lines the inside of the chest wall. Between these two layers lies the pleural space, which is not an empty void but a potential space containing a tiny amount of serous fluid. This fluid acts as a lubricant, allowing the lungs to glide smoothly against the chest wall during inhalation and exhalation. It also creates surface tension that helps keep the lung expanded and pressed against the chest wall. The key to normal breathing is the negative pressure within that pleural space. Section 3. Rib fractures, more than just a broken bone. A rib fracture is a break or crack in one or more of the bones of the rib cage. Though it may sound minor, treat rib fractures seriously due to potential life-threatening complications. Rib fractures are most commonly caused by direct trauma, such as from a motor vehicle collision, a fall, or a direct blow to the chest. The primary symptom that a patient will report is localized, sharp pain at the site of the fracture. This pain is characteristically pleuritic, meaning it worsens significantly with deep inspiration, coughing, or any movement of the torso. This severe pain is the central problem you must manage. When assessing a patient with a suspected rib fracture, your physical examination will reveal key findings. You will likely find point tenderness and possibly swelling or bruising directly over the injured rib. As the patient breathes, they will exhibit shallow respirations, a protective mechanism to minimize the painful movement of the chest wall. You might also feel or hear crepitus, a grating or crackling sensation under the skin. It is critical to perform a full respiratory assessment, listening for equal and clear breath sounds on both sides of the chest. The real danger of a rib fracture lies not in the broken bone itself, but in what that broken bone can do. The sharp, jagged end of a fractured rib can easily puncture the pleura and the underlying lung tissue, leading to a pneumothorax or a hemothorax. Section 4. Pneumothorax unmasked. When air invades the pleural space. A diagram comparing a fully expanded lung to a lung partially collapsed by a pneumothorax with air shown in the pleural space. A pneumothorax is the presence of air in the pleural space which disrupts the negative pressure and causes the lung to collapse, either partially or completely. For the NCLEX, you must be able to identify its signs and, most importantly, recognize the deadly progression to a tension pneumothorax. A pneumothorax can be spontaneous, occurring when a small air-filled bleb on the lung surface ruptures, or traumatic, resulting from a penetrating chest wound or a fractured rib. Regardless of the cause, the patient's presentation will be dramatic and acute. It is a classic breathing emergency. The hallmark signs and symptoms of a pneumothorax are sudden and severe. The patient will complain of a sharp pleuritic chest pain on the affected side, accompanied by an acute onset of shortness of breath, dyspnea. Your assessment will reveal key diagnostic clues. You will notice the patient is tachypneic and possibly tachycardic as their body tries to compensate. Upon auscultation, you will hear decreased or completely absent breath sounds over the affected area. When you percuss the chest on that side, you will hear hyperresonance, a loud drum-like sound that indicates trapped air, in contrast to the normal resonant sound of a healthy air-filled lung. The most dangerous variant is the tension pneumothorax, a true medical emergency. This occurs when air enters the pleural space on inhalation but cannot escape on exhalation, acting like a one-way valve. Air progressively accumulates, causing the collapsed lung to push the heart, great vessels, and trachea over to the unaffected side, tracheal deviation. A hemothorax is defined as the accumulation of blood in the pleural space. It poses a dual threat to the patient. First, the collected blood compresses the lung, preventing full expansion and leading to respiratory compromise. Second, the blood is lost from the circulatory system, which can rapidly lead to hypovolemic shock. Most cases are from penetrating injury, a stabbing, or a penetrating gunshot wound, or blunt trauma from a car crash that can fracture ribs and lacerate intercostal arteries or lacerate lung tissue. It can also be a complication of thoracic surgery. The signs and symptoms are a mix of respiratory distress and circulatory collapse. Like a pneumothorax, the patient will have chest pain and shortness of breath. You'll find decreased or absent breath sounds on the affected side on auscultation. A key distinguishing feature is the sound on percussion. Instead of hyperresonance with air, you'll hear dullness to percussion where blood has pooled. This is a critical assessment finding for the NCLEX. Be vigilant for signs of blood loss, hypotension, tachycardia, pale, cool skin, a weak, thready pulse, and anxiety or confusion. A chest tube drainage system is a critical intervention designed to restore the normal mechanics of breathing. Its role, remove trapped air. It also clears accumulated blood and drains other fluids to restore lung function. By removing these substances, the system allows the collapsed lung to gradually re-expand and function properly. The system works by re-establishing the negative pressure essential for keeping lungs inflated. For the NCLEX, you must understand how it works, focusing on three fundamental components: the collection chamber, the water seal chamber, the suction control chamber. The collection chamber is where fluid or blood drains and accumulates. It is calibrated in milliliters so you can measure output. Mark the drainage level, time and date on the chamber. Example schedule: every hour initially, then every 4 or 8 hours. Assess color and consistency of drainage: serous, serosanguineous, frank blood. Report sudden color changes or dramatic volume increases immediately. The water seal chamber is the second and arguably most important component. It acts as a one-way valve. It is filled with sterile water to about 2 centimeters. It allows air to bubble out on exhalation but prevents air returning on inhalation. You will observe tidling, a gentle rise and fall with breathing. Absence of tidling may mean full lung re-expansion or a kink blockage. Providing safe and effective care for a patient with a chest tube is a core nursing skill heavily tested on the NCLEX. Your responsibilities begin the moment the tube is inserted and continue until it is removed. Maintain the system's integrity, promote lung re-expansion, Prevent complications. Always keep the entire drainage system upright and below the patient's chest. Gravity helps drainage and prevents backflow. Coil the tubing loosely on the bed. Avoid dependent loops or kinks. Continuously assess the patient and the system. Regularly assess respiratory status. Work of breathing, breath sounds, oxygen saturation. Compare to baseline for improvement or deterioration. Inspect the insertion site dressing. Clean, dry, occlusive. Palpate for subcutaneous emphysema. Feel for crackling or Rice Krispies. Rapidly expanding crepitus is concerning. Maintain patency and security of the system. Securely tape all connections per policy. Never strip or milk the tubing routinely. It's outdated and a common NCLEX distractor. If clots are present, follow facility protocol, gentle manipulation or squeezing. Check water levels in the water seal and suction control at shift start. Add sterile water as needed. Documentation is critical. Be precise. Document drainage amount, document drainage color, document drainage characteristics, chart presence or absence of tidalling. If air leak, document degree, continuous bubbling, bubbling with cough, record wall suction setting, confirm suction control chamber function, gentle bubbling in wet suction, document respiratory assessment findings, document tolerance, including pain level, document effectiveness of any interventions. Differentiating between normal expected findings and abnormal unexpected findings is a key skill for a nurse managing a chest tube, and it is a frequent topic for NCLEX questions. Knowing what to expect allows you to reassure the patient and continue monitoring, while recognizing an unexpected finding prompts you to intervene and notify the provider. An expected finding in the water seal chamber for a patient with a pneumothorax is intermittent bubbling. This bubbling corresponds with exhalation or coughing as air leaves the pleural space. This is a sign that the system is working as intended to remove the air. Over time, as the lung re-expands and the air leak seals, this bubbling will decrease and eventually stop. Another classic expected finding is tidalling. The water level rises with inhalation and falls with exhalation. This gentle fluctuation confirms patency and pressure differential. Conversely, a common NCLEX scenario involves the sudden cessation of tidalling. This can mean full re-expansion or a kink, obstruction. Assess the patient and check tubing. Continuous, vigorous bubbling in the water seal chamber is an unexpected finding and a red flag indicating a large and persistent air leak. This could be from the patient's lung, but it could also be from a loose connection or a crack in the drainage unit itself. Troubleshoot by briefly clamping the tube near the insertion site to see if bubbling stops. One of the very few times clamping is permissible. While some drainage is expected after insertion, a sudden increase in bright red bloody drainage, for example, over 200 milliliters in an hour, is an emergency. This signifies active hemorrhage and requires immediate notification of the healthcare provider. Similarly, drainage that abruptly stops when it was previously consistent could indicate a clot or obstruction in the tubing. Finally, signs of infection at the insertion site, erythema, purulent drainage, warmth, fever are unexpected findings that must be addressed. Recognizing these red flags and acting on them is a hallmark of a safe nursing practice. NCLEX questions love to present you with a problem scenario involving a chest tube and ask for your immediate priority action. Mastering the troubleshooting process is therefore essential for exam success. Let's consider the most common emergency. The chest tube becomes accidentally dislodged from the patient's chest. This is a critical event because it creates an open pathway for air to rush into the pleural space, potentially causing a tension pneumothorax. Your immediate priority action is to cover the insertion site with a sterile occlusive dressing. The dressing should be taped on only 3 sides to create a flutter valve effect, allowing air to escape but preventing it from entering. After securing the site, assess the patient and notify the provider. Another common scenario is the disconnection of the chest tube from the drainage system. If the tubing becomes separated, the sterile integrity of the system is broken and the water seal is lost. Your first action should not be to clamp the tube, as this can cause a tension pneumothorax if the patient has an air leak. Instead, the priority is to create a temporary water seal. You should immediately submerge the distal end of the chest tube into a bottle of sterile water or saline, typically kept at the bedside for this very purpose. This prevents air from entering the pleural space while you prepare to reconnect the system with a new sterile connector or replace the entire unit. What if you see continuous bubbling in the water seal chamber, indicating an air leak? Your job is to locate the source. Start by checking all connections from the patient to the drainage unit to ensure they are tight. If the bubbling persists, you can, with the provider's order or per protocol, use a padded clamp to briefly and systematically clamp the tubing near the insertion site first, then move down. When the bubbling stops, the leak is proximal to the clamp. If bubbling continues when clamped near the patient, the leak is likely from the lung. If it stops, it is in the tubing or connections. As you prepare for the NCLEX, consolidating complex information into a simple, memorable checklist is an effective study strategy. Use this final review to solidify your knowledge of chest injuries and care. Run through these points mentally when you encounter a question on this topic. First and foremost, always remember the ABCs: airway, breathing, circulation. For any patient with a chest injury, focus on a patent airway, adequate breathing and oxygenation, stable circulation. This principle will guide your priority actions every time. Review the hallmark signs of each condition: rib fracture, pain on inspiration, risk of pneumonia, priority, pain management to enable deep breaths, pneumothorax, sudden shortness of breath, absent breath sounds, hyperresonance on percussion, hemothorax, shortness of breath, absent breath sounds with dullness on percussion, signs of shock, tension pneumothorax, life-threatening, severe respiratory distress, hypotension with jugular venous distension, tracheal deviation away from the affected side. Knowing these differentiators is crucial. Memorize chest tube rules. Keep the system below the patient's chest. Keep tubing free of kinks and dependent loops. Water seal your diagnostic window. Intermittent bubbling expected with pneumothorax. Tidling indicates patency. Continuous bubbling, probable air leak. Suction control, gentle continuous bubbling in wet suction, dry suction indicator, never strip the tubing, only clamp briefly for specific reasons. Locating an air leak, changing the system, be prepared for emergencies. Tube pulled out, apply a 3-sided occlusive dressing, tube disconnects, place tube end in sterile water, sudden change, acute respiratory distress, sudden gush of blood, rapid assessment of patient and system, call for help. Commit this checklist to memory to approach NCLEX chest injury questions with confidence. For the NCLEX, you must remember these critical structures and their functions. When a question describes a chest injury, visualize this anatomy. The ribs protect the chest, but can also become dangerous weapons if they fracture and puncture the pleura or lung. The pleura and the negative pressure in the pleural space are essential for keeping the lungs inflated. The diaphragm is the engine of breathing. Understanding this basic blueprint is the first and most crucial step in diagnosing the problem and identifying the correct nursing intervention when something goes wrong. Without this foundation, the signs and symptoms of chest injuries will seem like a random collection of facts instead of a logical sequence of events. Your priority nursing actions must be swift and precise. For suspected pneumothorax, assess the ABCs, apply high-flow oxygen, position in high Fowlers, prepare for a confirmatory chest X-ray, and anticipate chest tube insertion for large pneumothorax. If you identify signs of tension pneumothorax, especially tracheal deviation and hypotension, immediately call for help and prepare for emergency needle decompression. Do not fall for the NCLEX trap of choosing chest tube first. For hemothorax, airway first, oxygen, sit upright if BP allows, large bore IVs, rapid fluids and possible transfusion, labs and CXR, and large bore chest tube with vigilant output monitoring. A sudden gush of more than 200 milliliters of blood per hour, or your facility's threshold, is a critical finding. Notify immediately. The patient may need emergency surgery.